Dr. Hadley Wilson, President of the American College of Cardiology, and very happy to be with you here this year, albeit virtually, at CardioEgypt with our friends, Dr. Hassan, the chairman of your Egyptian Society of Cardiology 51st Annual International Conference, and also now with our joint session of the ACC with the Egyptian Society of Cardiology. I also want to acknowledge Dr. Farag, the president of the Egyptian Society of Cardiology, and also our incoming chapter governor for Egypt for ACC, Dr. Magdi Abdelamed. So once again, thank you for allowing us to have this joint session of ACC with the Egyptian Society of Cardiology on chronic coronary artery disease. And I will lead off by talking about, as you see, paradigm shift in stable angina management. And I have no financial disclosures. So everything we know recently about chronic coronary artery disease and the guidelines really, I think, are dependent and grounded on the ACC-AHA guidelines that were released at the end of 2021. A lot of that based on the results of the ischemia trial, and I'm going to try and go through this in the next few minutes, as I think it's very relevant to this paradigm shift that we have now seen in the last few years on treatment of chronic coronary artery disease. So important facts about the revascularization guidelines. We want to remember that they're patient-focused. This set of guidelines combined surgery, or CABG, with the PCI guidelines. It was a full revision, not just an update, and there was consistency across all other documents. Again, it's the recommendations focusing on the patient, and one of the class 1 recommendations is in patients who require coronary revascularization, our treatment decisions should be based on clinical indication and not on gender or ethnicity. And these are efforts, of course, to reduce disparities of care, particularly in those who are underserved. And then also, class 1 indication in patients undergoing revascularization is that the decision should always be patient-centered and also should be tolerant and considerate of the patient's preferences, goals, cultural beliefs, health literacy, and the social determinants of health, and made in collaboration with the patient's support system and family. And then also class 1 indication that in patients undergoing coronary angiography revascularization, we really need to be sure that we explain adequately the benefits as well as the risks, and that there's sufficient time for informed decision-making to improve clinical outcomes. And then finally, in those for optimal treatment strategy, where it's unclear exactly what is the best course, a heart team approach that includes representatives from the disciplines of interventional cardiology, cardiac surgery, and clinical cardiology is recommended to improve patient outcomes. So again, it's the focus on the patient to reduce disparities in care with the added shared decision-making of the heart team. So what about the recommendations specifically for revascularization to improve outcomes in stable patients with ischemic heart disease? So it's a class 1A recommendation that in refractory angina, despite medical therapy with significant coronary artery stenosis, if they're amenable to revascularization, it's recommended to improve symptoms, not to improve survival, but to improve symptoms. And this is compared to medical therapy alone. And again, as I started, based on the ischemia trial, which was released just a few years ago, very important, there continue to be multiple papers that are coming out reanalyzing the data, but you can see here from the ischemia trial the benefit of invasive treatment revascularization. That's for the surgery and CABG on the Seattle Angina Questionnaire summary score, both at 3 months, 12 months, and 36 months in improve of symptoms in those who had revascularization. And then also, what about revascularization with surgery, CABG, to improve survival in those with left ventricular dysfunction? Well, here we have left ventricular dysfunction in multivessel disease is a class 1A indication that they should receive CABG for ejection fraction less than 35%. And only a 2A recommendation, which means it may be favorable to improve survival in those who have mild to moderate reduction in left ventricular dysfunction, that is 35 to 50%. And again, a couple of major reports or studies, both in 2016 and way back in 1985 from the coronary artery bypass surgery studies, that showed and corroborated these results of improvement in survival for CABG with left ventricular dysfunction. And here you see, again, over a 10-year period, the separation in the lines with CABG in the blue line showing improved or less event rate over 10 years. The separation doesn't occur until after 3 years, but again, improved over medical therapy over the long term. And you can see also on the right panel, this was with 1, 2, or 3 vessel disease. What about PCI for left ventricular dysfunction? And this really harks from the recently reported revived BCIS2 investigators report, which was at ESC a couple of years ago and just recently published. And from their information, multi-vessel disease and PCI failed to show any improved event-free survival of left ventricular ejection fraction in those patients with severe ischemic cardiomyopathy. What about revascularization with CABG to improve survival of left main disease? Again, you see here it's a green 1A indication. In those that have acceptable anatomy, PCI may be a 2A indication, reasonable to improve survival, but again, not as strong as CABG. This is again from the original VA cooperative CABG study almost 40 years ago, again showing the dark line on the top, improved survival of CABG versus medical therapy over the succeeding 4 years in left main disease. And then a meta-analysis of early CABG trials. You can see right here on this left main bottom row here, 36% mortality over time with medical therapy versus only 5% with CABG. And again, what about PCI for left main disease? Okay, column 1, you can see it's pretty well equivalent in adequate anatomy to CABG on the top row. Definitely CABG superior to medical therapy here on row 2, and also PCI also superior to medical therapy in left main. So what about mortality or symptoms for revascularization in stable ischemic heart disease? Here you can see it's a 2A indication with multivessel CAD appropriate for either CABG or PCI by anatomy, that revascularization is reasonable to lower the risk of events such as spontaneous MI or unplanned urgent revascularization or cardiac death. And here's again another meta-analysis of early and contemporary trials supporting this. And what you can see here on the bottom row, the cumulative over this more than 20 trials, some of these even more recent, that again slightly favors revascularization and medical therapy over medical therapy alone for reduction in death or MI over time. What about for the choice of revascularization? So when PCI or CABG is preferred, again, I mentioned this earlier, but in patients with significant left main or high complexity CABG is preferred over PCI to improve survival on 1 indication versus a 2A indication for PCI, those with appropriate anatomy, and that would be a syntax score that's less than 33 or less complex disease. And again, it's reasonable that PCI can have a survival advantage, but if in complex disease or left main, CABG has the edge and is preferred. In patients with diabetes and multivessel CAD, again, CABG is preferred over PCI, a 1 indication. And again, this is mostly from the syntax trial in complex left main disease. Again, you can see the blue line with reduced events over the next 5 years with CABG versus PCI. In those with complex disease and left main, 21% cardiac death in the PCI group versus 8% in CABG over 5 years. How about complex multivessel disease? Again, the separation occurs after 2 years, and you can see long-term, again, significant reduction in mortality in complex multivessel disease with CABG versus PCI. And again, from meta-analyses, you can see that really, particularly from the syntax score, really takes place when you have the higher syntax scores, more complex coronary disease above 23 and certainly above 33, and also in our patients with diabetes What about our procedural recommendations? We're coming towards the home stretch here. The radial approach is preferred, and then in surgery with isolated CABG, radial artery for the second graft is also preferred, and also in patients undergoing PCI, now we're seeing shorter duration of dual antiplatelet therapy. Now 1 to 3 months is reasonable, with subsequent transition to monotherapy after 3 months, particularly to reduce the risk of bleeding events. And here on the left, we have the radial versus femoral pooled data, which again really shows, particularly on the bottom panel, in patients with acute coronary syndrome, that radial is better. Not so much in those with a combined group of stable ischemic heart disease and ACS on the top. But as far as bleeding, yes, significantly better in the radial approach for both groups. And again, this is more about PCI than surgery, but radial artery grafting, again, showing reduced MACE or death or MI over time as well. And then the duration of DAPT, again, primarily from the Twilight trial, but many others since then, that after 3 months, ticagrelor plus placebo not only had less bleeding at 1 year, but showed no difference, as you can see here, in terms of combined endpoints of death, MI, or stroke. So again, it's all about the patient. We want revascularization to improve survival of triple vessel disease. However, if they have normal or ejection fraction, it's only a 2B indication both for CABG or surgery, reasonable to improve survival, but not a strong recommendation. Same for PCI, useful to improve survival is uncertain in these two groups with normal ejection fraction. What about CABG for triple vessel disease and evidence favoring CABG again and triple vessel disease from a long time ago, the European Coronary Surgery Study, again almost 30 years ago, and then meta-analysis of early CABG trials, both showing multi-vessel disease, triple vessel disease, CABG better than medical therapy. And again, what about some evidence more recently favoring medical therapy? Again, it appears slightly stronger in those that have a revascularization plus medical therapy versus medical therapy alone. And this is the summary, and I wish I had time to go through all of this, but certainly happy to answer questions if time allows. But basically, this is the full part of the coronary revascularization guidelines as released from AHA and ACC in 2021. Summary: we need to reduce disparities in treatment and provide shared decision making, and remember the heart team approach. We also need to think about staging PCI of non-infarct arteries and STEMI, so that really makes them now less acute and in the chronic coronary disease group. We do want to have revascularization to reduce the risk of cardiovascular events, and CABG is preferred over PCI for complex disease, left main, or patients with diabetes and multi-vessel disease. Radial artery access should be the rule, both for PCI and for the second graft for CABG, and shorter durations of DAPT are being explored, where 3 months is required, and after that, with those with high bleeding risk, maybe P2Y12 monotherapy. So thanks once again for allowing us to be here. We'll have a couple of other speakers from the Egyptian Society of Cardiology, which I'm looking forward to hear. And then the Vice President of the ACC, your elected President-elect, Dr. Kathy Biga, will be ending the session here, also with some important information on patients who have coronary artery disease management. Thanks so much once again, and hope to see you next year or at the next meeting.
Thank you, Professor Hadi Wilson. And now we will move to the next speaker, Dr. Mustafa Muqarrab. Okay, we will give the lecture of Dr. Kathy Vega, the President-elect of the American Society of Cardiology. She will talk about microvascular angina guideline recommendations.
My name is Kathy Vega, and I'm the incoming president of the American College of Cardiology. What an honor and a privilege it is to be here with you, even if it is virtual. And I hope someday soon to visit Egypt, because I've never been there. In the meantime, I'd love to thank your incoming ACC governor of your chapter for Egypt, Dr. Abdelhamid, also your society president, Dr. Farad, and the person responsible for this wonderful conference, Dr. Hassan. What a great job you've done. We are looking forward to partnering with the ACC Egyptian chapter on the virtual Mideast conference, which will happen in October, and I'm hoping many of you will be able to join us. In the meantime, let's talk about something different right now. Let's talk about the equitable access to CV care. We've talked a lot about the different clinical elements that are required for taking care of your patients, but let's make sure we get the patients to that point of care. For those of you who may not know me, I'm from Chicago, so welcome from Chicago. It's actually a beautiful spring day here, although we're expecting some storms later on. But Chicago is a great place, and I have the honor and privilege of working with a little over 100 cardiologists and advanced practice nurses in 14 acute care facilities. You can see we ring right around Lake Michigan in the city. Not quite as beautiful as Egypt, but it does keep me busy in my day job. So what we're going to cover today in our short time together is why should we be concerned about disparities in CV care, and how is the American College of Cardiology helping as relates to our strategic plan, and maybe some practical strategies that you can actually take back with you to your hospitals in Egypt to eliminate disparities as an organization as well as within our practices. It was actually great fun putting this talk together because it allowed me to learn a little bit more about Egypt and your healthcare system. But let's start with what health equity really is. And it really is a simple definition that means everyone should have a fair and just opportunity to be healthy. And that's true whether it's in the United States or whether it's in Egypt. Because without health equity, we actually allow both structural and cultural barriers that decrease our ability to give care to our patient. And we actually fail to achieve social justice and our fulfillment of our professional responsibility to our patients. So it really has been an important campaign of mine to try to talk more. But let's first start with the definitions, make sure that we're all on the same page. So equality versus justice. Is there really a difference? I love this graphic because I think it really exemplifies exactly what we're talking about. We can see three individuals who all have the exact same container to stand on. And it's very interesting to me as a woman, and more places I go to do talks, they now give us a little platform to stand on so that we're as tall as some of our male partners. That's equity. Equity is giving somebody several stools to stand on so they can all see over the fence. A very important concept if we're just trying to do equity. But if we're still really talking about just care and justice in our healthcare delivery system, then we need to remove the barrier, which is the fence. So for our patients, we need to remove those barriers that prevent them from getting to us, whether it's from remote locations and transportation or whatever that barrier is. It's incumbent upon our CV team to remove those barriers for our patients. So let's talk about the social determinants of health. Probably not a new concept, but something that we don't really teach during training to our physicians, and we certainly have not been teaching it to our CV team members. So it's one of the things that I'm really anxious to make sure that we can get this word out, because it surprised me when I really looked at how healthcare is distributed and how important it is for our patients. It's really all about where they live. It's about their education. It's about their economic stability. Do they worry about where their next paycheck comes from? And then what kind of society and community are they living in? So that access to healthcare becomes so very important. If you're in a violent neighborhood, chances of you leaving to go seek healthcare becomes less and less. So then let's take a look at Egypt. What is happening in Egypt? Well, I found it very fascinating that there really was a full 2016 report on health and social justice really working towards a health equity perspective. It's been noted that the health sector in your country has been unstable for decades. And to tell you the truth, the United States isn't a lot different. Your 2014 Constitution actually addressed health care as a fundamental human right. Inadequate health care insurance, poor quality public health facilities, aging facilities, all contributed to that. And yet in Egypt, 72% of the costs are covered by families, at least in the literature that I was reviewing. And just recently, the World Health Organization came out with an operational framework that was released for how to monitor the social determinants of health. The Minister of Health are assuming that responsibility in different countries. And they're also looking at social determinants of equity, so very important for our cardiovascular patients. It should be noted that Egypt has come a long way. Hepatitis C is one of those areas that public health has really gotten better. You actually received a reward for this, and in 2030, the hope is to reduce that incidence and mortality with full elimination of Hep C. So congratulations on achieving that great milestone. Yet when we look at Egypt, our leading cause of death is still ischemic heart disease. You can see the difference from the white dot to the solid blue dot. You can see it's still getting worse. It's not getting better. So we've not reversed that. When is the first indication of heart disease? When do our patients come to us? Do they come to us when they have hyperlipidemia or if they have high BMIs, or is their first presentation as a heart attack, as we've just been listening to? And what are we going to do globally on cardiovascular disease and prevention? So it's important to realize that 20% of what we do for our patients is their outcome is determined by what we do. It's only 20%. 80% is determined by those areas that we just talked about. Socioeconomic, their physical environment, where they live, their diet, their exercise pattern, or the lack thereof, and how equitable is their access to health care. I think COVID put a spotlight on it, but in reality, it's much more evident now than it ever was, I think thanks to COVID. Education is critical. So if you leave with one thought today, please help us educate. Educate as to smoking. Educate, the more we educate people, the better their access to care will really be. Highly educated individuals tend to eat better. They find fresh fruits and vegetables. They tend to have a much better diet. Your diet in Egypt is obviously much better than ours in the United States, but yet we need to continue to educate to it. Because we have proven that there's a distinct biology to social determinants of health. That stress that comes from lack of education or lack of a job or poor housing or societal or family pressures really releases those stress hormones. It activates different things in our central nervous system. And there's no doubt that it ages us. So we do know that these social determinants of health absolutely have a biological underpinning, and we need to address them. Dipti Ichporia, which many of you know, she's been to Egypt several times. I'm hoping I'll get to visit you soon. But she talked a lot about health equity and the evolution of the quintuple aim. Of course, as we all know, that triple aim started almost 20 years ago, and it was really looking at patients and outcome and lower costs. Our quadruple aim added our CV team and added our physicians. But really, when it became the quintuple aim in 2021, just as COVID was exiting, health equity, that ability for better health and an improved economy is so very, very important. So something that is really important to us. And the college is really working hard to have a roadmap for health equity, making sure that through advocacy, education, and science, we can hit that goal of health equity. And advocacy is true globally. It is not just true in the United States. Working with our government is so very important as we look at health equity. Our health equity strategy starts with creating a culture. It's all about the culture of treating people the same, prioritizing health equity in everything we do, and to eliminate those disparities in care, making sure that we give the same availability of the proven science to all of our patients, a vision that we all need to have. And of course, as a CV team member, it's important to me that we redesign our team, how we deliver that health care to our patients, accountability and leadership, having quality outcomes so that we can prove the need for the interdisciplinary approach to access of equitable care. Knowing that we need our pharmacists, we need our dietitians, we need our nurses, and our social workers. It doesn't matter where we are in the CV team. Cardiology is a CV team sport. It is a sport that we need everybody involved in. And who provides our care is critical. Our patients need caregivers that look like them. We need to understand their culture, their language. So who provides that care becomes really, really important. Where we provide that care also becomes important. As much as we can meet the patient where they are is what we need to do. So in conclusion, a few takeaway points that hopefully will help you as you take this back to your hospitals and your clinics. Increasing the points of care where our patients are. How easy can we make it to have blood pressure checks and lipid screenings done? Working in underserved neighborhoods where people are unlikely, they don't feel safe traveling out of, so meeting the patient where they are. And building rapport and trust, those long-term relationships that I don't have to tell any of you about because you're so good at those relationships with your patients. And then providing innovative solutions and using AI. We don't have time today to talk about AI, but we need to use AI. It's a tool that will be very important to us as we transform cardiovascular care globally with your help. Thank you so very much. It was an honor and a privilege to be with you today, and I hope next year it can actually be in person. Thank you.
Thank you to Kathy for this nice presentation. Now to Mustafa Mukharram.
السلام عليكم ورحمة الله. طبعا أنا الحي اللي موجود هنا دكتور حسام فسيب لي براحتي شوية. بسم الله الرحمن الرحيم. It's a very tough subject to summarize when revascularize patients with chronic coronary syndrome. Actually, it is a very tough subject because it's the most gray zone in the guidelines. Professor Hadley enumerate all guidelines for patients. Professor Hadley explained all guidelines regarding revascularization in patients with chronic coronary syndrome. But الحقيقه يعني طبعا مفيش خواجات فهنتكلم براحتنا مش ده الستريت guidelines for revascularization, but we have a lot of gray zone for our patients. For example, this male 60 years lab for major cardiac surgery with positive non-invasive test is complaining only from dyspnea on moderate exertion. Of course, advised to do coronary angio. He has type distal left main stenosis. I think for guidelines and for prognostic point of view, revascularization either by CABG or BCI is advised and no rule for medical therapy alone. On the other hand, if you have the same scenario, but you have this type left circumflex lesion, can you leave it or dilate it or just medicate? This is the question. Dilate or medicate for such lesions? The first answer of this question is a change in nomenclature of term stable coronary syndrome. It's changed to chronic coronary syndrome. It means that chronic coronary syndrome as a dynamic process of atherosclerosis and altered arterial function that can be modified by lifestyle, pharmacological therapies, and revascularization, which results in disease stabilization or progression. The goal of therapy in patients with chronic coronary syndrome are alleviate symptoms and decrease the risk of adverse cardiovascular outcomes such as death, heart failure, and myocardial infarction. To this end, all patients should receive optimal medical therapy. One of the most important steps in guidelines is diagnostic evaluation for your patients. All patients with chronic coronary syndrome should undergo cardiac stress testing in part to identify those individuals who are likely to benefit from revascularization. It's very important for diagnosis and for risk stratification to do a stress testing for all chronic coronary syndrome patients. Stress testing is indicated soon after diagnosis is made and if there is a major change in symptoms status. And diagnostic coronary angiography may be advised based upon your non-invasive stress test regarding large amount of ischemia, evidence of multivessel disease, left main, and etc. What is the indication of revascularization? We have two groups of patients, either to improve survival, as in case of left main, multivessel disease, and low ejection fraction, and for symptoms relief for patients receiving medical treatment and uncontrolled on guidelines medical treatment therapy, or can't tolerate medical treatment. And it's very, very important point. Guidelines is clear for prognosis, left main disease more than 50%, proximal LED stenosis more than 50%. It's uncertain indication in American guidelines. 2 or 3 vessel disease with stenosis more than 50% with impaired left ventricular function. Large area of ischemia in non-invasive testing more than 10% of LV or abnormal invasive FFR. And this is new for indication for revascularization. ده الحقيقه بيزود الكونسيبت ان القصه مش اسكيميا بس، لا احنا بنتكلم على vascular element may change your decision from medical treatment to revascularization. Of course, single remaining artery and for symptoms relief patients not controlled on maximum medications. اوكي، coronary revascularization for mild to moderate ischemia. احنا كل اللي كنا بنتكلم عليه ده عيان عنده ejection fraction قليل او ischemia more than 10%. What about patients with mild to moderate ischemia? كل الترايلز CardioEgypt versus medical treatment, BTCA versus medical treatment, stents versus medical treatment in major clinical trials like Courage, Barry-2D, FAME-2 trial for beta and ischemia, all reveal that lack of benefit in death and MI. So why we still revascularize chronic coronary syndrome patients? Actually, this is a poll published on American College of Cardiology website after Orbita trial impact. السؤال كان what change in PCI volume have you seen in stable coronary artery disease? 90% من الدكاترة اللي جاوبوا على السؤال no change، مش حاجة اتغيرت. So, despite this results from previous medical trials, no change in practice. Look for this picture. It's a very nice place, very nice picture. I love it. I like it. And also, for this picture, it's nice picture, but not nice place. But by some photo editing, البعض مننا ممكن يقول لك الجملة دي This photo makes me motivated to die. الكلينيكال ترايل الحقيقه احيانا بتبقى كده، لما تبص لها من بره حاجه and if you go in depth you may find something different. Okay? This is earlier comparison between medical treatment and revascularization done by Hakamovich in retrospective analysis, and he concluded that patients with myocardial ischemia on stress test who underwent early revascularization had a lower all-cause mortality and cardiac mortality during long-term follow-up as compared with medical therapy alone. Of course, it's a retrospective single-center trial, and there is inequality between medical arm and revascularized arm. Following years, many trials comparing medical treatment and revascularization in patients with chronic coronary syndrome. All these trials reveal that no difference in mortality and the myocardial infarction. Only we have revealed angina relief and the quality of life improvement till Courage trial. Courage trial, no difference in mortality and no difference in angina relief after 5 years. And the conclusion of Courage trial was that PCI did not reduce the risk for death, MI, or other major cardiovascular events when added to optimal medical therapy, and also with no between groups difference in angina-free status at 5 years. later on varied to, and also there is a criticism for courage trial. As we know, it's randomization done after coronary angio, bare metal stent, a lot of patients, crossover from medical arm to invasive arm, and selected patients, all enrollment patients have no severe ischemia, only mild to moderate ischemia. But look for this diagram. The long-term survival in courage trial determined by number of diseased arteries, not by ischemia itself. This is very important. احنا دايما قاعدين نتكلم على الاماونت اوف ischemia، والترايل بتقول لنا لا الاماونت اوف ischemia ما بتفيدش بحاجه، ده number of diseased artery and it's a vascular element and not ischemia element. Very two trial diabetic patients armed with invasive strategy and armed with medical treatment, and the same result, no difference in survival or cardiovascular death. But CABG arm had a lower non-fatal myocardial infarction versus optimal medical treatment with no difference in survival. Again, around 40% of cases cross over from optimal medical treatment to revascularization. اوكي، احنا مش هنبص للاناتومي بعينينا، لا احنا هنشوف السيفيريتي اوف coronary artery disease by FFR in a very important trial, FAME 2 trial, comparing medical treatment versus invasive strategy in patients with stable coronary artery disease using FFR. Again, this no difference, but urgent revascularization, invasive arm better than medical arm, and also myocardial infarction, invasive arm better than medical arm. And this improvement maintained over 5 years. And in conclusion, in patients with stable coronary artery disease, FFR guided BCI improved patients' outcome as compared with medical therapy alone. And very important point, this trial is purely anatomical and the invasive physiological assessment, no ischemia burden at all. Okay, another criticism for this trial, soft endpoint, randomization within 7 days, and symptoms analysis may be nocebo or placebo effect. انت عامل عيان قسطره والتاني بياخد ميديكال تريتمنت، جايز اللي اتعمل القسطره بلاسيبو افكت بيقول ان انا اتحسنت. طيب still we are revascularized patients with chronic coronary syndrome. ليه؟ We have several studies have shown that myocardial revascularization by BCI or CABG more effectively relieve angina, reduce the use of anti-anginal drugs, and improve exercise capacity and the quality of life compared with medical therapy alone. Among patients with multivessel disease, the assessment of frequency of angina and the quality of life measures in Syntax, Freedom, and Excel trials consistently showed early and sustained improvement for both BCI and the CABG during long-term follow-up. This is a meta-analysis done 2014, comparing revascularization versus medical treatment in patients with stable coronary artery disease, and the results were that CABG and BCI with new drug-eluting stents improving survival better than medical treatment alone. And this is another meta-analysis 2021 comparing mortality in patients randomized to elective coronary revascularization plus medical treatment or medical therapy alone, and also the results that revascularization arm has improving reduction in cardiac death and in new myocardial infarction, and this is maintained for long-term follow-up. So, remember also the 5-year follow-up of FAME 2 trial confirmed the same results, sustained the clinical benefit in patients treated with BCI versus medical treatment. These data support a less restrictive indication for revascularization in chronic coronary syndrome in addition to specific anatomy. مش هنتكلم بس على الليفت مين والاماونت اوف ischemia، لا، there is another indication for revascularization in such case. Okay. The old trial ممكن نقول ان هي bare metal stents, low or moderate risk, no new drugs and new tools. Now we have ischemia trial. Ischemia trial كلنا عارفين، انا مش هتكلم في الانكلوجن ولا الاكسكلوجن ولا الترايل نفسها، لكن الترايل كان فيها الستريس ايمجنج، نيوكلير ايمجنج is there, multi slice CT, QCA, FFR, and IFR. In conclusion, although this trial didn't show a reduction in death or myocardial infarction, ischemia trial confirmed that an early invasive strategy resulted in better symptoms relief and angina-related quality of life. العيانين دول في أول سنة كان عندنا 45% reduction in angina في الريفاسكولارايزد ارم مقارنة ب 15% بس in treated medically arm. Improvement in angina continuing over next 4 years on weekly basis. Remember, exclusion criteria of ischemia trial: left main disease, acute coronary syndrome, highly symptomatic patients excluded from the start from trial, heart failure or high likelihood of unprotected left main coronary heart disease, judged by physician. Again, this is a guideline. Again, we speak about large amount of ischemia, which may be not true, ischemia alone or with other high risk feature. And also another question, what about role of myocardial revascularization in patients with moderate to severe ischemia and silent or mild to moderate angina, high threshold nociceptor pain, revascularize or leave them for medical treatment, and vice versa. Patients with very low mild ischemia in lung invasive test and severe symptoms in real life, revascularize or not. This is analysis from ischemia investigators examine both the prognostic predictive power and the potential trial treatment interaction according to the degree of ischemia demonstrated by stress testing, mainly nuclear imaging, and anatomic severity of coronary artery disease. يعني بيقارنوا البريدكتيف باور ايه اللي هيحكم على العيان اللي عنده ريسك اكتر من الثاني، الثانيه او البرفيوجن ايمجنج ولا عدد الليجنز اللي في الشرايين. They demonstrate that the extent of ischemia is poor discriminator of the risk for most clinical endpoints, while irrespective to the ischemic burden, the severity of coronary artery disease was a strong predictor of outcome across nearly all clinical endpoints. And remember, from the long-term survival encourage also no effect for ischemia in long-term survival, only the number of diseased arteries. So the question is this: ischemia or extent of anatomic coronary artery disease is a marker for greater atherosclerotic burden. And if so, majority of Black are non-obstructive, but may be vulnerable. So can we consider Black characterization and vulnerability as a new target in treatment of chronic coronary syndrome patients? يعني لو انا عملت ايفاس او سي تي للعيان even حتى لو هو ما بيشتكيش ولقيت signs of vulnerable Black or maybe high Black burden, revascularize them or not. So this is editorial في 2021 forget ischemia, it's all about Black. What is the clinical implication of ischemia trial among patients with stable coronary heart disease? Coronary computed tomography may be superior to stress testing for risk prediction within the narrow range of ischemia severity in individual enrolled in the trial. Ischemia severity may not identify patients with stable ischemic heart disease who benefit from invasive management over 4 years. Coronary CT may be more efficient method than ischemia testing for risk stratification and may inform decision making for potential benefits of an invasive approach for patients with severe coronary artery disease. So, Mr. Chairman, dear colleagues, this is my final home message. Both anatomical and functional assessment are to be considered. Either non-invasive or invasive functional evaluation is required for the assessment of myocardial ischemia associated with angiographic stenosis. Revascularization, poor prognosis, and symptoms relief are clear indication, but clinical judgment Availability of IVUS, OCT, and FFR are of great help. Black characterization is a good target for management and decision making. In patients with angina, shared decision making should occur to align treatment with patients' goal and preferences. And thank you.
شكرا دكتور مصطفى. A very nice lecture actually. احنا كده خلاص متفقين انه revascularization doesn't improve mortality in chronic coronary syndromes. It's just the aim is to do angina relief. Yes, okay. قصة بقى انك to prevent acute coronary syndromes and the vulnerability detection برضو اعتقد ان هي still لحد دلوقتي هي something theoretical، يعني ما فيش اي بروف من الكلينيكال داتا ان انا لو عملت كده العيان هيستفيد. فبالتالي احنا لحد دلوقتي ملخص كلامك ان احنا عيانين الكوروناري سيندروم are for medical treatment except لو العيان is symptomatic تمام و resistant to medical treatment او
can tolerate الميديكال treatment
او can tolerate ما هو whatever. لكن based على الاناتومي والاسكيميا سايز still we have to do intervention ولا لا؟ النقطة دي يعني عايز بس تستريس عليها علشان انت قلت حاجات عكس بعض.
هي مش عكس بعضها، هو الموضوع
في حاجات داتا قديمة وداتا جديدة ونفس الوقت الطريقة اللي بتأسس بيها والطريقة اللي بتعمل بيها الانترفنشن والتولز بتاعتك ونوع الستنس وكل دي فاكتورز. بس في الآخر أنا عايز أوصل انت في رايك انا العيان ده اللي انا هلاقيه ليفت مين اللي انا هلاقيه الاسكيميا سايز اكتر من 10% اعمله ولا ما اعملوش بيزد على اللي موجود عندي دلوقتي والستنس اللي موجوده حاليا وافيلابل.
طبعا clinical data if I have a patient with left main disease ischemia more than 10% multi-vessel disease impaired left ventricular function it's for revascularization. السؤال بقى الثاني اعتقد انك حضرتك بتسال
انا هعمله انجيو ليه عشان الاقي مالتي فيسل او ليفت مين وهو اصلا ما هو دلوقتي موضوع السيمتومز خلاص احنا طلعناه من
احنا اتفقنا
انا هعمله ليه انجيو؟
في الاول خالص اتفقنا ان السكريننج فور كرونيك كوروناري سيندروم بيشنتس باي نون انفيزيف تيست ده مانداتوري.
تمام يبقى انا بتكلم دلوقتي على الاسكيميا سايز اكتر من 10%
او هاي ريسك فيتشر اناتوميكال هاي ريسك فيتشر
بالسي تي
او امبير ليفت فنتريكولار فانكشن
بالسي تي
وهو الحقيقه الاسكيميا ترايل
امبيرد لحد كام؟
35
يعني اقل من 35
اقل من 35
وفايبل مايوكارديوم
وفايبل
لازم فايبيليتي
لازم فايبيليتي وبرضه الفايبيليتي انذر ديبيت
how to predict viability what is the best method يعني I can rely على nuclear assessment ولا I have to do CMR ولا الستريس ايكو يعني ايه هي الميثود اللي انا هعتمد عليها ولا هي الافيلابل ميثود؟
available method from the start لكن البيست طبعا السي ام ار for detection of viability افضل من النيوكلير ايميجينج اند ايكو ستريس.
في اي سؤال دكتور مصطفى تاني؟ اتفضل. دكتور عبد الحليم الرونالد استاذ القلب في طب الازهر.
انا اشكرك على المحاضره القويه دي.
شكرا جزيلا
وانا من زمان واقول عليك ان شاء الله انا جاي لك مخصوص عشان المحاضره بتاعتك. فيعني انت من الناس الشطار عندنا في الاسم والناس الممتازين عليك وربنا يوفقك. هو المشكله دلوقتي الميديكال تريتمنت مع الانفيزيف تريتمنت مع الكاب 3 حاجات اللي هم اساس العلاج بتاعنا. المشكله بقى في العيان نفسه. لو عيان كرونيك وستيبل خدت بالك في منهم بيبقى موافق يعمل الانفيزيف وبتاع ولو يبقى سيمتوماتيك وكده. انما انا عايز احل لكم برضه المشكله. لو عيان كرونيك اسكيميا وستيبل مثلا وعملت له سي جي انفيرو اسكيميا وبالنيوكلير والحاجات مايلد اسكيميا فده مشي على العلاج وخصوصا لو هو خارج في الارياف مع منطقه صحراويه وكده مشي على الميديكال تريتمنت واعمل له جرعات. انما لو عيان في المدينه عشان ده اندر ستريس وعنده ضغط وعنده سكر والدكاتره هتلعب في دماغه لازم تعمل قسطره وعمل اكسرسايز سيستم بيطلع ايكو فوكال فده اعمل له قسطره وريح دماغك عشان ايه؟ تحل مشكله. لو لقينا بقى في مالتي فيسل وبتاع بنعمل ريفاسكولاريزيشن، لانها ستيبل ومفيش اي ريسك، بس خلاص نمشي على العلاج زي بتاع الالياف. والكابي بقى يعني دايما احنا بنقفل عليهم بالبي سي اي وبالقسطره، فيعني ونتائجنا في البي سي اي بقت مشابهه للكابي، وان كان هم ما زالوا احسن مننا في اللونج تيرم مع العيان المالتي فيسل ودايابيتك وكده، انما ما زال البي سي اي واخده سيكونس. فهو احنا تبع حاله العيان ده، هو خارج القاهره وستيبل ولا في القاهره. واحنا نشكرك.
هو طبعا لو من اسيوط برضه هنعتبر البي سي اي.
ايوه، ما هو
طبعا شكرا.
ما هو لو في مدينه خلاص يبقى كويس، انما لو خارج في الصحراء بقى من اسيوط او في وجه بحر الارياف يبقى ماشي على التمرين.
طبعا يعني شكرا جزيلا دكتور عبد الحليم على الكلمات اللي ارجو ان انا استحقها يعني. هو الحقيقه زي ما شفنا في الجايد لاينز بروفيسور هادي، الحقيقه الجايد لاينز الجديده بتعتمد على حاجه مهمه جدا، الشير ديسيجن بما فيها البيشنت بريفرنسز، يعني البيشنت عاوز يعمل ايه. كان في ترايل مهمه قوي الحقيقه في المايو كلينيك، جابوا العيانين كرونيك كوروناري سيندروم وقعدوا معاهم بعد ما عملوا لهم قسطره وفهموهم الهازارد اوف مايوكارديال ريفاسكولاريزيشن والفاليو اوف ريفاسكولاريزيشن والهازارد اوف ميديكال تريتمنت اند فاليو اوف ميديكال تريتمنت وبوشنج هيم تورد الميديكال تريتمنت، لان هو ده كان الايم من الترايل. في اخر الترايل الكونكلوجن ان العيانين اصبحوا فيري knowledgeable as regard chronic coronary syndrome، لكن ولا واحد منهم غير الديسيجن. كان about 80% من العيانين preferring revascularization over medical treatment. فالبيشنت بريفرنس طبعا ده مهم جدا.
شكرا دكتور مصطفى for the elegant presentation as usual. وفي نقطتين، يعني الانديكيشنز فور ريفاسكولاريزيشن فور مورتاليتي حضرتك ذكرتها وواضحه، ودي يعني ليها بوينتس معينه كلاس 1 ريكومنديشن وتحسن المورتاليتي. لكن حتى المرضى اللي هم مش في هذه الكاتيجوري، احنا بس عشان شغالين في الكارديولوجي وكل شغلنا مورتاليتي بنفيت وتعودنا على كده، انما الكواليتي اوف لايف از فيري امبورتنت. ده في تخصصات كامله قائمه على الكواليتي اوف لايف فقط، بيصرف فيها مليارات يعني للكواليتي اوف لايف، والعيان عنده سيمبتومز يعني دايما هيفضل اسكينج فور ريليف.
الكلمه دي الحقيقه اتقالت من اول الكارج ترايل، لان في كل الترايلز اللي قبل الكارج فيها الكارج ترايل كان الكواليتي اوف لايف هي الفيكسد احسن مع البي سي اي، احسن مع الريفاسكولاريزيشن. وده السكيميا ترايل 2020 ذا سيم فايندنج، الكواليتي اوف لايف احسن بكتير قوي مع العيانين اللي عملوا انفيزيف ريفاسكولاريزيشن ايذر كابج اور بي سي اي. والحقيقه برضه كابج اند بي سي اي ايذر باي anatomical definition or physiological definition، او عمل بي سي اي guided by angiography and QCA، وعمل جروب تاني guided by FFR. البوث جروبس احسن من العيان اللي مشي على ميديكال تريتمنت. يعني العيان اللي عمل بي سي اي او ريفاسكولاريزيشن ان جنرال ايذر فيسيولوجيكال جايدد اور اناتوميكال جايدد كان احسن من العيان اللي مشي على ميديكال تريتمنت.
شكرا. اي سؤال تاني؟
هو بس طبعا في الاول لازم نقول لك الف مبروك على المنصب الجديد، وربنا يجعله لك بالنفع كله ان شاء الله حبيبي. انا بس كنت عايز اسال سؤال بياند ان الاو سي تي احنا بنستخدمه او ما بنستخدموش او حاطينه في البلانز بتاعتنا في مصر او لا، لكن هل ستيل الاو سي تي نقدر نمشي وراه في حاجات معينه؟ يعني انا لو في الكرونيك ستيبل بيشنت هل الاو سي تي اقدر احطه كبارامتر لوحده في حاجه معينه، ولا ده برضه هرجع واقول لا انا
طبعا دكتور حسام هو الفرق بين الاو سي تي والايبس في الكاركترايزيشن. يعني الايبس هاي بنتريشن وبالتالي بنعتمد عليه في الكلاسيفيكيشن اكتر، في الكاركترايزيشن اوف لاك الليفت مين فور اكزامبل. الاو سي تي فيري هاي ريزوليوشن، وبالتالي لو انا اقدر احكم من الاو سي تي على ان دي فالنربل بلاك اور ثرومبس كونتيننج ليجن فور اكزامبل، هتكون اكتر من الايبس فور ديسيجن ميكنج اند جايد ماي ديسيجن تورد ريفاسكولاريزيشن. ده في ايفيدنس للحاجات دي موجوده. طبعا الكلام زي ما الدكتور حسام بيقول ان البلاك كاركترايزيشن لسه مش في الجايد لاينز، لكن من بعد الاسكيميا ترايل والكلام اكتر واكتر على ان احنا ما نهتمش بالاسكيميا في البرفيوجن ايمجنج، لا نهتم اكتر بالفسيولوجيكال اسسمنت، انفيزيف فسيولوجيكال اسسمنت اند انفيزيف ايمجنج بيتر ذان نيوكلير ايمجنج. الحمد لله الدكتور عادل علام مش موجود النهارده.
طيب شكرا لحضراتكم، وكده احنا بننهي اخر سيشن في المؤتمر، ونلقاكم على خير العام القادم ان شاء الله.
الف مبروك دكتور حسام.